different areas, but probably into the health professions.
Right.
Okay, I'll do an intro for you.
Hello everyone, thank you for coming out. It's my absolute pleasure this morning to introduce you to Professor Robin Room. Professor Robin Room works at multiple institutes. He wears many hats. He's a sociologist who has spent the last 35 plus years working on alcohol, social implications of alcohol and drug use, and also problem gambling. He is the director of the Centre for Alcohol Policy Research at La Trobe University, and is also an honorary, has an honorary position within the School of Population and Global Health. He has written 30 books, has over 300 publications, and has been an advisor to the World Health Organization since 1975. So please join me in welcoming Robin here today.
Thanks very much. Yes, I came into the field actually for a summer job for 2 months, so be warned, it's quite attractive field, but low prestige, which has great advantages because people don't complain when you go mucking around in their territory, because alcohol gets into very much so many different parts of our lives, essentially, that you end up studying tourism, you end up studying, obviously health issues, and you end up studying things like domestic disputes and family violence. So I'm going to talk about the role of public policy in managing harm from alcohol, and I would welcome, excuse me, I would welcome people. Wave your hand like anything if you want, if there's something that comes up that you don't understand, or just shout out. And we'll see whether we have a couple of minutes at the end for discussion. So the learning objectives are that I'll try and show you that alcohol is among the leading risk factors globally for health, and the risk is not just for the drinker, and it's not just about health. Societies like ours accept unique levels of risk for alcohol compared with other risks that we spend a lot of time trying to prevent. There's a need for greater attention to alcohol globally and locally, and rates of alcohol-related problems are mostly rising, although alcohol consumption among youth is down. There are strategies which will reduce harms, but they require political and popular will, and they go against vested interests. It can be done, as I'll argue at the end, has been shown for tobacco and drink driving, and there are some signs of change, and my argument would be that public health interests ought to seize the moment. So alcohol is a pervasive risk factor in various terms. The first I'll talk about is in terms of the overall risk to health globally. Now, there's a thing called you may have heard about it earlier in the course, the Global Burden of Disease series of studies that are mostly funded by the Gates Foundation these days, although WHO carries out its own Global Burden of Disease work as well. And the main thing they use as their indicator of harm to health is DALYs, disability-adjusted life years. In other words, how many years are you losing from life either by death or by being disabled in one form or another. And the most recent of these estimates are now being published in Lancet, and I'm focusing here on what's called the risk factors, where they look at the different risk factors for the overall health of the world. And alcohol, in those newly published, last week published figures, comes out 19th as a risk factor for women, but 4th as a risk factor for men. In other words, all over the world, in nearly every culture you can think of, the men drink considerably more than the women and get in much more trouble because they also behave worse. Alcohol and drug use overall, if you put alcohol and illicit drugs together, they're 8th among the risk factors, but 95% of that risk is from alcohol, over 95. So basically, yes, we worry a lot about, politicians worry a lot about ice, and they worry a lot about, these days actually, about prescription opiates with some reason. But alcohol is not on the political agenda in countries like Australia if they can avoid it. Here's the leading risk factors globally in this set that was published last week, and you can see on the left there's women down there at number 19, And there's a lot of other things that are above it, and you can study this at your leisure. We're not going to spend time on it now. But over there on the male side, smoking is number one, but the second most important behavioral factor in the risks to health internationally is alcohol use, at number 4 for the risks. This is from an earlier version of the global burden of disease. In a way, alcohol is the most complicated of the major risk factors. It looks like kind of a field marshal's battle ribbon or something, a set of ribbons. Each of those different colors represents a different illness or injury that alcohol has a causal role in. If you look very closely at this chart, you can see that it has that the alcohol row is the only row that has a little bit off to the left of the 0, and that's the protective effects. You can see that yes, there are some protective effects from alcohol to health, but compared with the adverse effects, it's just no comparison. I think actually the global burden folk have actually lowered the amount of protective effects that they now attribute to alcohol. Because of that field marshal's ribbon, because it's so, it contributes to so many things, to non-communicable diseases, to infectious diseases, to injuries, obviously, and also to mental health, it tends to be dealt with in a very uncomprehensive way. You'll find that it's within the World Health Organization, the responsibility for it is split between a number of different pieces. And in health ministries, the same thing goes on. There's nothing much going on around prevention of alcohol problems, for instance, in the health ministry in Victoria. They used to worry about it, but they've given up on it, essentially. So that really anything that's being done about alcohol in the preventing alcohol problems in the Victorian government at this point is through the Justice Department, essentially, and the Liquor Licensing Authority. So there are injuries, violence and also accidental injuries. There are mental disorders. There are infectious diseases and non-communicable diseases. And if it's organized under any one division, for instance, in WHO, it's mental health and substance abuse has now been sort of squashed into non-communicable diseases. Well, you know, it's not a very high priority in the non-communicable diseases area, even though it's one of the 3 major behavioral risk factors. Other connections tend to be neglected once you lump it into one division of the department or another. This is somewhat older data from the mid-2000s about the proportion of different kinds of DALYs, disability-adjusted life years, that are attributed to alcohol that are in different parts of the International Classification of Diseases. You can see that if you look internationally, about 40% of the DALYs are from injuries, essentially, up there on the right-hand 28 plus 12. About a little under 40% of mental disorders. In terms of non-communicable diseases, that adds up to about 17%. And since the whole stuff about alcohol and infectious diseases is not very well fixed, they don't even have an estimate of that even now in the NCDs, even though tuberculosis and also sexual infections and so forth have an alcohol component to them. Different parts of the world, as you can see, if you want to look at it again later, have different patterns in terms of what predominates, but Eastern Europe, if you look along the row at the bottom of the percentage of the burden of disease which is alcohol-related, you'll see that it's mid-income and richer countries which have the higher proportion that is of the burden of disease which is alcohol-related, and particularly Eastern Europe has the highest proportion. There's current major global efforts on non-communicable diseases, and alcohol is recognized as one of 3 important risk factors, but and that's a plus, and it's included in this major effort, but from the point of view of worrying about alcohol, it means that the global efforts were reorganized with a focus on NCDs, which tends to neglect major alcohol health problems that aren't NCDs, for instance, injuries. And the targets and indicators for alcohol are considerably more modest than the targets and indicators for tobacco, for instance, which are much more spelled out, partly because of the Framework Convention on Tobacco Control. The harm from alcohol, the third thing to say is that the harm from alcohol is not only to the drinker and not only to health. We tend to focus on, well, there's the bad liver, there's the other things that happen to the drinker if they really drink a lot. And there's substantial health burdens, but there's also social burdens. It decreases functionality, and then often people around the drinker are substantially adversely affected, and the larger society is also potentially adversely affected by too much drinking. Here's results from an Australian population survey we did about 10 years ago. We've got a proposal in now to do it, another one 10 years later. 29% of Australian adults said that they were affected at least a little negatively by a family member or friend's drinking in the last year. And 9% said that, out of that 29%, a third of them said they were affected a lot. Young women were the most likely to be adversely affected. Young men and middle-aged women were also more likely to be affected than older men and women. The types of effects are quite diverse: lost time, which they had to care for the drinker, emotional hurt and neglect, serious arguments, failure in social roles, and financial effects, and so forth. A child the respondent was responsible for was adversely affected by an adult's drinking. 17% said at least a little, and 3% said a lot. If you look at the negative effects of drinking by strangers in the same survey, 70% reported one or more negative effect from strangers drinking in the last year, but some of that is about fears and amenity, about not liking to go out to the tram stop because there are a couple of drunks standing around there. And it's more affecting the amenity of the neighborhood than a direct effect on the respondent. 40% are negatively affected at least a little, and 4% are negatively affected a lot. And again, it's young adults, 18 to 29, most likely to be affected. Young females slightly outranked young males, but that's not a significant difference. And the tangible and personal effects there that we were asking about were property damage, serious arguments, threats, verbal abuse, and physical abuse. The cost of alcohol studies, which are part of the cost of illness tradition of trying to measure what's the cost to society of this particular illness, and if you do it for alcohol, then traditionally the costs that they've counted have been mostly the costs to the governments of one sort or another, and often some costs also to the drinker, although the economists argue a lot about whether that should be counted or not. We counted in the costs that we could measure in our survey from that were to interpersonal costs, in other words, to other folk in interactions around the drinker, and that more or less doubled the cost if you did that. That's what this chart shows. So alcohol is a source of both health and social harm, and unmatched among widely ingested psychoactive substances is a risk factor to the health of the drinker. In terms of the range of health harms, harm to others from drinking is apparently unmatched by harm from other psychoactive substances. We don't have good measures of that, but it seems to be way out of the box in countries like Australia that drink quite a lot. It's not just the widespread heavy use, it also reflects the intrinsic harms of the substance. And so I'll show you a couple of things from studies that have appeared in the last few years which are not affected by, not paying attention to how much someone is using of the substance, but more looking at intrinsic harm. This is a rating by a set of psychopharmacologists. It became quite controversial because people said it didn't make sense to rank them on a single ranking. I think that reflected underneath that they were uneasy about the fact that the illicit substances don't come out at the far left. And you can see that alcohol, once you count in harm to others as well as harm to the user, alcohol in their ranking came out top, above heroin and crack cocaine and methamphetamine. Cannabis is somewhere there in the middle, and so forth. This is a different comparative risk assessment for regular users, which uses what's called a margin of exposure approach. In other words, measuring the difference between what would be a adverse effects level and what is the human use level. And you can see that the red is the average result, and the gray bar is for people who've drunk a lot of alcohol regularly and therefore are tolerant. And you can see that, or whatever the substance is, you can see that, again, alcohol comes out as the most risky down there at the bottom in terms of what the ratio is of those two levels, essentially. And, you know, on this one, cannabis comes out as the least risky. So this is mostly, essentially, about overdose and poisoning, but not only about that. For alcohol, levels of risks that are socially accepted are way beyond the usual norms. This is a study we did of 6 European countries, putting them together and looking at and they were a mixture of countries, going from the sort of hard-drinking north down to Italy, and which is drinks much less these days than it used to, and is actually drinking less than Finland. The risk of dying prematurely up to age 70 because of alcohol consumption for those countries. You can see out of this that even in terms of grams per day, the risk came out less for women. Now, that's taking account of injuries and other kinds of harm, again, reflecting the fact that men tend to behave worse than women, or behave more riskily than women. Yes, if you look at the chronic illness charts, then if you get up to somewhere around 40 grams a day, then women have a stronger risk of cirrhosis, for instance, than men do. But that's outweighed by this kind of behavioral part of it. We've gone a little bit into the issue of what levels of risk do our societies usually accept before they start deciding that something should be controlled or illegal or whatever. For involuntary risks, Australia sets it at 1 in a million around. If you are drinking tap water, then there should be less than a 1 in a million chance that you're going to die of cancer in your lifetime that is due to the tap water, to contaminants in the tap water. That's the standard that's set in Australia, and the standard that's recommended by WHO is that it should be lower risk than 1 in 100,000. For voluntary risks, like bungee jumping or canoeing or rock climbing, we clearly accept much greater risks than that. And if you look at how it goes in countries like Australia or the US, then the level at which the society begins to say, no, that's too risky, don't do it, is somewhere around 1 in 1,000 chances that you'll die if you do it over a lifetime. The risks from alcohol consumption, of course, are a mixture of voluntary and involuntary. I'm running risks to my liver, for instance, when I'm drinking alcohol, a few drinks a day or something. But then, you know, if someone runs into me who's been drinking in a drink driving casualty, that's not something I volunteered for. But if you look at automobile driving, for instance, which is, again, a mixture of risks that are voluntary and risks that are involuntary, Australia aims for a lower lifetime risk than the level that's set in our low-risk drinking guidelines. The low-risk drinking guidelines were set at a rate essentially of 1 in 100 for your lifetime risk. For automobile driving, we're aiming at the Australian policy is to aim for it being less than 1 in 200. So the low-risk drinking guidelines that are now being revised by the National Medical and Health Research Council, NHMRC, Health and Medical Research Council, use that kind of measure of risk I've been talking about, which is lifetime absolute risk basis. And you can see there they said no more than what amounts to, well, 2 fairly small drinks of alcohol per day average over a lifetime. And no more than 4 drinks on an occasion. If you do that twice a week or less, then your lifetime risk of death from alcohol-related injury is less than 1 in 100. So even when we're setting lifetime, when we're setting low-risk drinking guidelines, we're defining low risk in a way that is higher than the risks that we would often accept for other behaviors. Factors that are involved in alcohol's unique status in European and related societies, including Australia. First of all, it's not regulated as an addictive substance under the International Drug Control System, and that reflects that there's a strong cultural acceptance and influence of the alcohol industries. In Australia, there's a particular history of having had a very strong temperance movement in the 19th century and early 20th century, and then a very strong reaction against it. Don't be thought a wowser in the Australian term. That really had a very strong influence on the politics, I would say up to the last 10 or 20 years, when the most important influence probably keeping alcohol less regulated than public health folk would like has been deregulation and the neoliberal consensus. It's not treated as other food products. For instance, it's exempt from the mandated list of ingredients and nutrition labeling that you'll find on anything else you're taking into your body and it's not controlled as a carcinogen. If you go to California, you'll discover when you wander into a liquor store there, it has to have a sign outside that says, note, alcohol is a cancer-causing substance. You don't get that on the bottle in Australia. Public health community is often ambivalent, which reflects that kind of don't be a wowser tradition. Public health in Australia was quite strongly allied with the temperance movement. If you go back, not only in Australia, but in other countries also, if you go where temperance was strong, if you go back to the 1920s and so forth, then they had to escape that in the 1950s. And the public perceptions underestimate the risk. So where can we go in terms of a stronger response on alcohol? Firstly, let me tell you a bit about what the global story is so far. WHO has a checkered history on alcohol. WHO is really the only international agency that takes substantial, has had any substantial effort on alcohol. There was a little burst of effort in the very beginning of WHO because the first psychiatrist they hired to head the mental health section at that point was interested in alcohol and brought a leading person in the alcohol field, Jelinek, on board for about 4 or 5 years. There were early expert committees, but the emphasis was on alcoholism, on the disease alcoholism, since that was seen as a way that you could talk about alcohol that didn't mean that you were being a temperance person. And the new mental health chief, when he came along, had no interest in alcohol at all, so that just disappeared. In the mid-70s to 1983, there was support externally from the US for specific studies and then from Nordic countries. And there were World Health Assembly technical discussions and resolutions on alcohol in 82, 83. But then the alcohol industry got organized and got to the Director General, and the production and trade study was, in WHO was closed down in 1983. And what you had for a decade or so was non-controversial small projects in the mental health division. Then there was a separate program on substance abuse that included drugs, and then it came back to mental health. So it was a very mixed picture with probably an average of about, in a global way, of about 2 or 3 people in WHO staff who had who were seriously involved in alcohol issues. There was a spurt of activity in the up till 2010. The global burden of disease studies, when they emerged and found alcohol to be a leading risk factor, meant that it couldn't be avoided, couldn't be ignored the way that people tended to do. Nordic countries started to push for a new World Health Assembly resolution, and it was approved in 2005, finally. And in 2006, there was the first expert committee on alcohol that there had been since the only previous one in 1979. 2010, a global strategy to reduce the harmful use of alcohol was adopted. The long wording of that, the to reduce the harmful use of alcohol was a victory for the alcohol industry, which didn't want it to be a global strategy on alcohol. The global strategy, here's the Director General, who went out of office just the beginning of this year, talking at the time of the global strategy being adopted. It's a true breakthrough, she said. It gives you a large and flexible menu of evidence-based policy options. But then there's further symbolic recognition in the 2010s, but the alcohol program remains starved of resources. If you look at the, and I've put some stuff there that you can look at, but if you look at the professional staff in international agencies who are working on drugs, it's something like in the hundreds, if you count the UNODC in Vienna and so forth, somewhere in the hundreds. Tobacco, in and around WHO, it's in the dozens. With respect to alcohol, it's less than 5, essentially. So what is to be done internationally? In international law, and there's a stark divide in psychoactive substances. Heroin, cocaine, amphetamines, and diazepides and so forth are in international treaties which are backed up by national laws which say that use essentially is limited to prescription for medical use and usually with a prescription. And one thing that hasn't been noticed about those treaties, which have a lot of problems from my point of view, and I think from a public health point of view, is that they do apparently provide de facto protection against trade disputes. No pharmaceutical company has gone with a trade dispute about a drug that's covered under the conventions, essentially. There's nothing in the conventions that stops them from doing that, but they think it would be too much of a blot on their reputation to do it, I think is what's going on. With the Tobacco Convention, which separately adopted in the early 2000s under WHO auspices, the Framework Convention on Tobacco Control, it's a relatively soft law compared with the drug treaties. It encourages but doesn't require national actions. Alcohol is not in either of those. It has legal markets and weakened controls, and it comes under international trade treaties and disputes, as also does tobacco, because they couldn't get that into the Tobacco Framework Convention. So those trade treaties undercut national public health policies on alcohol and tobacco. For instance, there's one that we've been writing about now, which was the Trans-Pacific Partnership, and is a model. It's a section of that that's a model for new international trade treaties, for instance, the one between Australia and Singapore, which is about wine and spirits labeling. The industry has become worried about the fact that governments may be moving towards requiring warnings and so forth on what they consider their valuable real estate, that is the label, the main label of the bottle. And so they've built into these trade treaties a provision that governments, that if governments require such warnings or lists of ingredients or things like that, they have to be on, the industry can insist that they be on a supplementary label rather than on the main label. What you have in these kind of trade disputes anyway is when you have something written in like that, even if what you're doing would be arguably technically legal under that provision, you can get frightened off by the fact that you're otherwise having to pay some tens of millions of dollars to fight off a tobacco or alcohol company in international trade disputes. One option is to bring alcohol into the drug treaties. I actually proposed that at the Expert Committee on Drug Dependence, where I was a technical advisor in 2012 and got someone who was an actual full member to propose it with me. The drug folk blanched, and really it was referred, as they put in the report, the Expert Committee referred the matter for consideration at a future Expert Committee meeting. And when they had another expert committee meeting in 2014, it also deferred it to a future meeting. If considered, alcohol would clearly qualify. If recommended, it would probably go under the Schedule 2 of the 1971 treaty. In the wording of the treaty, it clearly would qualify for listing under the conventions. But If it were scheduled, you'd have to do something to amend the treaty so that you don't say that it's limited to medical use. Unless you're willing to say that you're willing to limit alcohol use to something that has to be prescribed. So there's strong resistance from those in the international drug control system to jolting the apple cart. The alcohol industries have already been fighting hard also against per capita alcohol consumption as an indicator of reduced non-communicable disease risk. And putting, although it certainly is, a good indicator, and putting alcohol into the framework of controlled substances would be an important step forward in public health, but it's not going to happen this year or next year. You could have a separate framework convention on alcohol control, which was what the tobacco people decided to do with respect to tobacco, the anti-tobacco people in the public health world. You would need to modify the framework convention on tobacco control for alcohol's special characteristics, that we do so much of the drinking together in public places, for instance. You'd have to provide for limitations on marketing and promotion, as the tobacco control tries to do. But it would also be good if you could build into it countering coverage of alcohol under the trade treaties, which they failed to do for the tobacco treaty. The important thing about such a treaty is it establishes what's called comity between nations. That is, that a nation doesn't undercut another nation's laws, which is what often happens with respect to alcohol, for instance, at this point. It's a structure for international coordination also, so there's regular conferences of parties and so forth. You would rapidly get up to the situation where there were more than 5 people in international civil servants working in the area. The third option would be adopting a new single convention that included tobacco and alcohol as well as the drugs that are now illicit. I would argue that that should, more than the current single convention on drugs does, leave the internal market up to each country, but require comity, as I explained it, and an international oversight agency, and that public health and order considerations take precedence over trade and free markets. So that's the international side in a nutshell. And in Victoria, drinking levels are high by world standards, but there's some decline in younger cohorts. Teenagers are now moving into the 20s, are drinking less than their older brothers and sisters did 10 years ago. But alcohol-related harms mostly seem to not be going down. And that's an interesting puzzle that a couple of my colleagues are working on at this point. So this is various measures of it, ambulance attendances that have to do with alcohol and emergency presentations and so forth. So what's going on? Because trends in alcohol problem indicators usually match consumption trends. Patterns of drinking are changing, so there's more harm per litre. Is there a polarization of drinkers going on where heavy drinkers drink more while lighter drinkers drink less? Is the falling relative price of the cheapest alcohol affecting poor marginalized drinkers and they show up more in the harm problems? Are the response agencies, the emergency department folk and the AMBOs, paying more attention to the alcohol dimension? We're not clear about the answer to this, but researchers are looking. In the meantime, we have a relatively well-developed literature on what would reduce the harms. The issue is political and public will to adopt the measures. WHO's best buys for cost-effective prevention include increasing taxation, limits on availability in terms of hours of opening and numbers of stores, limiting marketing and promotion. Also important are drink driving enforcement, brief intervention on heavy drinkers by people in the primary health system, and counseling and reintegration. Some strategies are ineffective, although they're often popular and often something that politicians will agree to. Voluntary industry codes are have very little effect, essentially. Alcohol education in schools, if it's something that you're doing by itself without anything going on outside the window, the kids can look outside the window and see that they're being treated and told things differently from what's going on in the larger society. Warning labels, the most we've been able to show with the American warning labels is that when they first came out, at least, they started some discussions among people, but that was about it. Public service messages, it's very difficult to show effects for them in the alcohol field, partly because governments are afraid to do the kind of thing that governments have ended up sometimes doing with tobacco. You can show some effects with the tobacco public services messages. There was one in California that ran for a while which said the tobacco industry, this was funded by the state government, it said the tobacco industry is not in business for your health. That would be much too strong a message for any government in Australia, I think, to put out. Promoting alternatives, alcohol-free activities. There's often a good reason to have a basketball court or whatever it might be, but it doesn't, but as one of my colleagues once said, you know, the problem with alternatives to alcohol is that they combine, so many of them combine so well with alcohol. Designated drivers and ride services, again, at the in an individual case, that may be useful to have one of you decide that you're not going to drink that night and drive the rest home. But the studies that have looked to see if there's any aggregate effect from any overall effect from encouraging that have not found any effects. So the 10 best practices based on the international evaluation literature are, several of them are in this area of alcohol control that I've already mentioned. The one thing that most countries can agree on is a minimum legal purchase age. It's actually lower in Australia, for instance, than in the US, or a little bit lower than Sweden. Government monopoly of retail sales. I argued recently, and I got in the newspapers, that that would be a good thing for the Northern Territory to think about monopolizing the liquor stores in the Northern Territory, particularly with the banned drinker register, would mean that they would have a much easier time keeping that properly so individual data doesn't leak out. Restrictions on hours or days of sale, alcohol outlet density restrictions, and alcohol taxes. We have a very peculiar tax system in Australia, as many wine countries do, where the cheapest wine is paying something like 1/10 of the tax that beer or spirits are paying as a percentage of, by percentage of alcohol. Drink driving countermeasures. Australia and Victoria in particular, as I'll talk about in a minute, have a strong record in this area that was an early record at least, and it has been kept up more or less. And brief interventions for hazardous drinkers, which don't affect a large proportion of the people who get those brief interventions, and so people start saying, oh, well, it's not doing anything. But it doesn't cost that much for the doctor to put on the white coat and say, well, you'd be better off if you drank less, and it affects about 10%. So if you look at the cost effectiveness of alcohol strategies, as economists have done in preventing illness and death, this is a study which is actually concerns about 15 years ago, but you can see the taxes down there on the as highly effective, and since the government collects money from the taxes, it's got a negative net cost to do that. Advertising bans are seen as being relatively effective. Licensing controls on operating hours, you can see there, so that in terms of the net cost to the government, some of the things that can be done actually would make the government money. What is politically feasible is often ineffective, and what is effective is often politically difficult. This is my attempt at a kind of summing up of what happens with the different strategies for preventing alcohol problems. At this historical moment, there's pressure in Australia to do something, but politicians strive to do something that isn't disturbing the market. But there is some signs of ferment. There's a liquor licensing inquiry underway at this point and hasn't yet reported in Victoria. New South Wales and Queensland have done earlier closing hours with positive results. The Northern Territory is trying to institute its own set of measures that go beyond the banned drinking register. So there are some signs of firming. My argument is that alcohol ought to be brought into the central concerns of public health, that any policy change should be evaluated, and building provision and funding for evaluation should be built into any policy change. And the Australian governments are doing fairly well on that, though they tend to be a bit cheapskate about how much they will assign in terms of money for evaluation. I'm near the end now, and let me just talk about a couple of examples that alcohol can learn from. One of them is reducing tobacco deaths. This is the Australian experience, which you can find American studies that describe it as being, these were particularly studies, I think, before the plain packaging, but that described it as not being terribly dramatic from a public health point of view. But you can see that the number of cigarettes per capita fell by half over a period of 30 years with a sustained effort on the part of health authorities and public health NGOs and so forth, with higher taxes, advertising bans and controls, smoking bans in workplaces and restaurants and pubs, graphic warnings, and of course in Australia also so far a world leader in plain packaging. Nicotine replacement products, I think, are a part of this story, although not so much for Australia. And of course, health professionals had quite a strong role in this. A second Australian success story was reducing drink driving casualties. This was part of a sustained drive to reduce traffic deaths. It wasn't specifically only about drink driving. Which has had whole of government coordination at a relatively high level in Victoria, which is unusual in Australian governments. With a Traffic Accidents Commission, one of the things that happened was that the state essentially took on responsibility for the insurance of traffic. And that meant that the state had a vested interest in driving down the traffic crash rate because it would save them from the point of view of insurance. And the MUAC, the Monash University Accident Research Centre, which is funded by the state, played an important role in providing the evidence and evaluating. And there were a series of measures that had an effect on drink driving. Compulsory seat belts is one of them, random breath testing, cameras around speed and so forth. You can see that the road deaths in 1970, there were over 1,000 road deaths in Victoria, and by 2013 there were 242, even though there was a much larger population and many more cars. So this was a really successful public health campaign that went on for has gone on now for pretty close to 50 years, which you can see there are times, if you look at this BAC chart on the right hand, you can see there were times when things slacked off a little and then they turned up the screws again. So if you think of those two examples, what characterizes the success? There were clear public health goals to reduce the harm to a minimum, a consensus that was strongly shared in the population that the existing burden was unacceptable, professionals, particularly the doctors with respect to smoking, as advocates, a long-term perspective in terms of decades, not just something that's going to be a campaign that we're going to get finished this next year. You know, our centre is gets its core funding from a non-profit foundation that has a lot of business folk on its board, and the board members apparently are asking, well, you know, we've been funding these guys for 10 years. How come the problem isn't solved? You can't go into this with the idea that it's going to get solved next year or the year after that. This is going to be a long, continuing campaign. Cross-sector collaboration, which I think is really important for these issues like alcohol that really reach across government departments. initiatives in terms of what's possible at the time, but they accumulate over time. If someone had told me 20 or 30 years ago that it would be an issue around whether parents should smoke when their children are in the car, that I would have said, you're out of your mind. It's just crazy to think that anyone would worry about that. Or for that matter, that the idea that you wouldn't have smoking in bars, in pubs. Sometimes the unthinkable becomes possible. There are some signs of change in drinking in the society. As I said, a decline in drinking levels, particularly among youth and young adults. Multiple bottom-up campaigns that are not sort of started out by professionals, PEBFAST, Dry July, particularly Hello Sunday Morning, for time off from drinking and re-examining intoxication. Changes in how many drinkers or in what volume drinkers consume don't necessarily change the trouble per litre, but they offer a supportive social climate within which you can work. And there's a new political will to reduce alcohol-related harms. Family violence, the review of the Victorian Liquor Control Act was partly motivated by the Royal Commission on Family Violence, saying, look, not enough attention has been paid to alcohol, we need to have a review of the Act. In New South Wales and Queensland, it was much more around street violence in terms of their pullbacks in late-night alcohol sales hours. So I would argue it's a promising moment for public health promotion, and thanks for your attention. Anyone have any questions, or? Yep.
I was just wondering, you mentioned before that the early approaches focus largely on alcoholism as a disease. Obviously, that's sort of one of the more visible aspects of it. But in your opinion, like, what percentage of the harm does that actually account for? Like, people who are visibly alcoholic?
Yeah. It all depends how you define what is alcohol, what is the interest of alcohol. But often you find that the really serious things like hallucinations, that this is about half, that yes, there's a much higher rate among people who are really drinking heavily. But, it's occurred, and there are a lot more people than those people who are drinking, sort of 4 or 5 drinks a day. And, they're also drinking, they're slightly under somewhat elevated risk. So, the lesson I would argue is that taking care of the alcoholics is something that is good, something that is important for a humane society to do it. But it's not really a way of reducing alcohol. The main way in which I would argue is to see some evidence of it having effect on alcohol is if you employ a lot of folk to be treating alcoholics, the alcohol and other drug treatment system, you employ some people there who then have a professional and vested interest in it and start talking about it. And so it's more that they're paying attention to the problem and you have professionals talking about it that creates some effect in the larger society than actually the fact that they're talking alcoholics. Because, what last one was about is now no longer on, it's still there, and someone else fixes the problem. And one last thing to say about that is that Australia has a very strong temperament. It's not something that we think about and know about, and we're not taught about it in reform history. But for instance, in Victoria, where it was very strong, it affected the government set in motion around 1900 a Victorian commission which essentially was in charge of reducing the number of pubs in Victoria. And over a period of 10 or 15 years, they were big out ones that considered to be more noxious. And the government paid compensation to close that pub. And half of the pubs in Victoria closed over a period of 15 years. Now that's a quite dramatic action. You can't imagine a current government being trained to do it. It was very hard when I proposed the monopoly, government monopoly for the Northern Territory, the
switch this up.
Is that okay?